Welcome to Mental Health in the Age of Climate Crisis. For those of you who are new to CMHRC, my name is Elizabeth Errico. I am the Children's Mental Health Resource Center's founder and executive director. Our mission is to provide guidance and resources to families as well as professionals who are living with or treating early onset mental health conditions in the pediatric and adolescent population. We believe that through early intervention, we can have the most impact on creating positive trajectories for children throughout the lifespan. Now, before we dive into the content, we're going to take a quick look at our learning objectives for today. By the end of our time together, you should be able to define the clinical relationship between climate change and psychiatric illness, identify the psychological mechanisms that are at work that are affected by climate change, examine how children, women, and Indigenous communities face distinct vulnerabilities, and give examples of ready-to-implement tools that you can use right away in your clinical practice. Now, right now, this week, as we speak, Western Europe is under an excruciating heat dome. In France, these extreme conditions are expected to last at least until the end of the week, with daytime temperatures in some towns above 40 degrees Celsius. That's 104 degrees Fahrenheit. In fact, a spokesperson said yesterday that further record-breaking temperatures are expected, including some that could surpass all previous records, regardless of the time of year. Climate change is tied to increasing extreme weather, and UN Climate Agency projections say that the next 5 years could shatter more heat records. Last week, a tornado destroyed a shopping mall outside Cincinnati, Ohio, where a member of our community works. According to a study published in April of 2004 in the Journal of Applied Meteorology and Climatology, since 1951, tornado activity has been shifting away from the Great Plains and toward the Midwest and southeastern U.S. The number of days with meteorological conditions favorable to tornadoes has declined in parts of the original Tornado Alley, while tornado days have increased significantly east of the Mississippi River. Cities like Dallas and Austin are seeing far fewer tornado days per decade, while the traditional tornado epicenter has shifted eastward 400 to 500 miles. This is showing a significant upward trend in tornado frequency in portions of the Southeast, Midwest, Northeast, with increasing trends specifically documented in Mississippi, Alabama, Arkansas, Missouri, Illinois, Indiana, Tennessee, and Kentucky. These impacts are not abstractions. They are a reality that our patients live with every day. So over the next 90 minutes, we are going to move through what is an urgent public issue, but also a deeply practical one. And I want to address one question head on that might be looming for some of our audience and make one thing clear. This is not a political conversation. Our approach accepts that climate change has been scientifically established, with 97% of the world's climate scientists concurring. The fact that climate change is endorsed by every major international and US scientific body, including the United Nations and our own space agency, NASA. So whether you or anyone else listening in the audience personally believes that this change is taking place because of human activity or not is not relevant to the conversation today. What we are doing is translational. We are bridging the gap between the known science and the practical consequences it has for the patients that we see in our practices every day. So whether you are a counselor, a social worker, a psychologist, a nurse practitioner, psychiatrist, or educator, This content is directly relevant to your work. So we're going to start with our first learning objective. Define the clinical relationship between climate change and psychiatric illness. The United Nations defines climate change simply as long-term shifts in temperatures and weather patterns. That definition sounds deceptively simple and unthreatening, given what it encompasses in practice. What it looks like from a practical standpoint is catastrophic storms moving inland to regions that have never experienced them before, like with Hurricane Helene. Wildfires occurring in what were previously low-risk areas. 100 consecutive days of temperatures above 100 degrees in Phoenix, Arizona in 2024. Flooding that permanently changes the landscape families have lived in for generations. The rising prices for food, for energy costs that we live with every day, and homeowners insurance rates climbing out of reach or being cut off altogether. I want to anchor us in the concrete because when we talk about climate change and mental health, we're not talking about distant abstractions. We're talking about what your clients and patients lived through last summer or last winter and what they're bracing for in the year to come and experiencing right now while we're gathered here. Now, we're talking about the relationship between climate and mental health. So we're going to jump right in and talk about something that patients and families often report that clinicians sometimes dismiss because unless you've experienced it, it doesn't seem like it should be real. And this is the sense that mood changes occur before storms arrive. This is neither imagined nor merely anecdotal. The barometric pressure drops that precede storm systems have real physiological stressors. They affect the body's vestibular system, the level of pressure in the fluids in the joints, and vascular tone, all of which have downstream effects on limbic stability. And we know from past clinical seminars the degree to which the limbic system and dysfunctions within it can exacerbate symptoms of mental illness or become involuntary symptoms in and of themselves. When a patient tells you that they or their child started having mood fluctuations or that their child started raging 2 days before a hurricane hit, believe them. It's clinical data. It also means that climate change, which is producing more frequent and more intense storm systems, is expanding the frequency of these pressure-related psychiatric triggers. You may, on the other hand, find that the opposite is true with some of your patients. They're not making connections between their mental and physical health and the environment that they're living in. You may even find that in clinical practice, you have patients repeating inaccurate information that they've heard, and maybe they genuinely believe, though it is in fact incorrect. So we need to understand what misinformation is, disinformation is, and what the difference is between the two. So misinformation is shared by mistake or misunderstanding. It's not intentional. When misinformation is corrected, the person generally corrects and updates their thinking or statements that are associated with this misinformation. Disinformation, on the other hand, is deliberately false. It is designed to deceive and is shared to manipulate public opinion. It is intentional and it is designed to be resistant. This presents a significant clinical problem, however. When we have a client who believes disinformation, they may actually wind up avoiding health protective behaviors and evidence-based health decisions. They may be skeptical of heat warnings or dismiss the connection between weather and symptoms. And while we can't correct them, we can share with them compassionately evidence of the truth to help them understand. You can't, as a clinician, none of us can control what our clients believe. And pushing them to let go of that disinformation that they believe can result in distrust in us and damage that therapeutic relationship. So it is not our job to argue politics with our patients, but rather to stay grounded in evidence and to help them make choices and changes that help them feel better. The best way to arm ourselves as providers is to know the facts, learn to identify disinformation, and be ready to model the acceptance and change required when we realize that we've heard misinformation so that we can support our clients in identifying the connections between their lived experience, such as sleep disruptions or mood fluctuations, and weather events like heat and storms. So remember, when we're talking about mental health, there is no separating mental health from physical health. That means when we discuss climate change and its effects on the body, we're discussing mental health as a physical health emergency. This sounds simple and easy to understand, but its importance really can't be overstated. The relationship between climate change and mental illness is bidirectional. Increases in frequency and severity of extreme weather directly impacts people's mental health. It means that more people are exposed to environmental traumas, which can be a trigger for the onset of PTSD and depression, or a trigger for past traumas to develop into PTSD. Similarly, chronic and systemic climate-related stressors like rising food costs, energy insecurity, housing instability due to climate change, it keeps people in an elevated state of physiological distress, which also increases overall psychiatric risk across the lifespan. Additionally, increased rates of neurodevelopmental disorders such as autism spectrum disorder, learning disabilities, ADHD, and intellectual disabilities are associated with heat exposure during prenatal development. This data represents intergenerational psychiatric risk from climate change. Finally, suicide rates increase with temperature increases. Studies have demonstrated up to a 2.1% increase in suicide rates for each degree rise of 1 degree Celsius. Now we're going to follow our second learning objective, identify the physiological mechanisms at work affected by climate change. Now, the temperature globally is expected to rise 4 to 12 degrees Fahrenheit by the year 2100, depending upon future emission levels, of course. This large range reflects a difference between continuing our current trajectory and taking climate action. But regardless of what temperatures are in the year 2100, we are seeing the effects of increased temperature today, and we have been for years. As I mentioned earlier, 2 years ago in 2024, Phoenix, Arizona experienced 113 consecutive days with temperatures above 100 degrees. Of all the ways climate change affects human health, this rising temperature, this heat, is the most immediate and most documented for people living with mental illness. Heat is a neurological stressor, and the human body's normal functioning actually becomes disrupted in temperatures above 95 degrees Fahrenheit. This temperature-driven disruption has been shown to increase interpersonal violence, hate speech, and as we mentioned just a moment ago, even suicide. Sunlight itself, which of course is essential for human life, can also have detrimental effects in excess. For people living with bipolar disorder, for example, increased sunlight exposure has been shown to trigger manic episodes, especially during the seasonal transitions between winter and spring, as well as during the summertime. Combining excessive sunlight exposure and increased heat is a known cause of seasonal symptom resurgence and relapse in bipolar disorder. So when we talk about these challenges, it is important to put the scale of the problem into context. So 1 in 5 American adults live with a mental illness. 68% of all adults report eco-anxiety. 54% of adults develop depression following a natural disaster. And people with schizophrenia are more than 200% more likely to die during a heat wave than members of the general population. Take a moment to let that sink in. Not 10%, not even 50%, but over 200% more likely to die. This is not a marginal risk. This is a clinical crisis embedded in heat wave or heat dome forecasts, warnings, and advisories. Now, an additional layer of concern is the interaction between heat and mental health that stems from the fact that medication-induced thermoregulatory impairment is a serious and urgent risk as ambient temperatures rise. There are many psychiatric medications that impair the body's ability to thermoregulate by interfering with the hypothalamus, which is the brain's temperature control center. These medications can inhibit sweat production, which is the body's primary way to self-cool. And it can also alter thirst levels and fluid balance in the body. These impairments they're already known, and many medications that have this effect already carry warnings about temperature-related side effects. Now, we're talking about medications such as both typical and atypical antipsychotics, which can cause anhidrosis, meaning the body literally loses the ability to sweat. And without sweating, the body can't cool itself naturally, and hyperthermia becomes a medical emergency. SSRI and SNRI antidepressants literally cause excessive sweating, which leads to both dehydration and electrolyte imbalances. Sorry, I always have trouble pronouncing this one. Anticholinergic, well, it's on the screen. Block the parasympathetic pathways that the body needs to self-cool. And central nervous system stimulants, such as ADHD medications, can elevate metabolic rate and increase heat production while reducing heat tolerance at the same time. And mood stabilizers, such as lithium, which affects thirst and can lead to dehydration and vulnerability, can result in toxicity during hot weather and excessive heat. Patients on lithium who sweat excessively in the summer without adequate hydration can move into the toxic range without warning, threatening their ability to continue to take this life-saving medication, which research shows if it is taken and then stopped and then taken again, can show reduced efficacy once it has been reintroduced. So avoiding excessive heat for someone taking lithium is a health protective measure to ensure that they don't have to stop taking it, even for a temporary period of time. Now, these are not rare edge cases. These are medications that are prescribed daily for the most common and pervasive mental health disorders in the country. And the risks compound when patients are taking more than one medication at a time as part of a cocktail. This commonly happens, though, due to the need to address co-occurring disorders and complex conditions like bipolar disorder, like schizophrenia. So I want to stress, these are essential medications that can make the difference between life and death for countless people worldwide. Yet the associated thermal disruptions do put individuals taking these medications at a higher risk for heat exhaustion, heat stroke, or in cold environments, accidental hypothermia, and even under normal temperature circumstances, which wouldn't be considered extreme because with cold tolerance, they're unable to detect how cold their body is becoming. When we add in rising temperatures associated with climate change and shifting weather patterns as a result of climate change, we are putting individuals with mental illnesses at even greater risks. Now, hurricanes, wildfires, tornadoes, floods, other significant weather events, which are specific and time limited, unlike ongoing heat increases, expose individuals to life-threatening danger, loss of home, displacement, the sudden destruction of everything familiar, and the loss of loved ones. These things, they don't resolve when the storm abates. These are lasting traumas. And as individuals manage and cope with this exposure, they're at significantly increased risk for developing post-traumatic stress disorder. Likewise, seeing community destruction, injury, and even death creates powerful traumatic memory imprints that can reemerge for years. Sustained traumatic stress extends beyond the event with displacement, financial stress, and loss of community. Finally, as climate change continues to intensify, many individuals will experience repeated climate disasters, compounding the trauma before recovery from the last event. Before that has been resolved, a new trauma has arrived to compound it. If not properly identified and treated, this trauma can become a risk factor for mental illnesses. They can cause intrusive memories, hypervigilance, avoidance, and emotional numbing, which are all part of post-traumatic stress disorder. Grief over the loss of one's home, personal belongings, community safety is compounded by displacement, financial devastation, and disrupted social networks, which can move a person towards major depression. Persistent hypervigilance and fear of future events can generalize beyond storms and become anxiety disorders. And trauma-driven emotional dysregulation can persist as instability, irritability, and impulsivity. When we widen our lens to include pre-existing socioeconomic and psychosocial factors that are associated with mental illness in general, we see that individuals and families living with mental illness have an even harder path to stability in the context of climate change. So what do I mean by this? Well, stigma, it's real. Stigma impacts a person with mental illness in everything from job opportunities to housing access to social and emotional isolation. Stigma-based challenges compound existing disadvantages and expose individuals with mental health conditions to economic and social marginalization. We like to think that stigma isn't a problem anymore, but as we understand it, there's a big difference in public perception between mental health conditions and mental illness. As a result of some of the socioeconomic and social marginalization that goes along with mental illness stigma, Individuals living with mental illness are less likely to have air conditioning. They're less likely to have access to those heat warning alerts, and they're less likely to have practical and social supports that are needed to protect them when those temperatures rise or those storms hit. The psychological vulnerabilities that go along with mood disorders, not just disrupted thermoregulation, but sleep disturbances, metabolic dysfunction. It can make the brain's response to heat even more severe. Again, these compounding socioeconomic and psychosocial factors also limit, or at least make it more challenging to recover from these disrupted physiological responses. Now, I referenced the limbic system earlier, and the truth is that it's at the neurological center of today's presentation. The limbic system regulates emotion, memory, stress response, motivation, and body temperature. These functions, they're not separate systems that are running in parallel to one another. They're deeply integrated with one another and impact mental health. The amygdala is the early warning system. It evaluates threats, stores emotional memories, and activates the fight, flight, freeze response when needed. The hypothalamus is the thermostat of the brain. It regulates temperature. It regulates sleep-wake cycles, hormones, and it communicates bidirectionally with the amygdala. The hippocampus provides the narrative context for what's going on in the brain. When external temperatures rise, the hypothalamus is put under direct physiological stress. It has to work harder to maintain homeostasis. And when that system is strained, especially in someone who already has a mood disorder or already has a thermoregulatory disruption, we see what looks like a psychiatric crisis. Understanding this architecture is part of what allows us to stop calling heat-driven symptoms behaviors and start calling them what they are: physiological medical events. Now, the human body maintains core temperature within a range of 97 to 99 degrees Fahrenheit. When that range is exceeded, even modestly, we begin to observe changes in behavior and in mood. The heat aggression theory, validated across dozens of cross-sectional and longitudinal studies, tells us that elevated temperatures increase hostility and aggressive thoughts. Cities with higher average temperatures show consistently higher violent crime rates, even after controlling for poverty, age, race, and culture. And for people who already live with mood disorders, those whose thermoregulatory threshold is already compromised, these effects arrive faster and they hit harder. What looks like a rage or a meltdown, which is how parents often describe these episodes, or an inability to follow directions when they occur in a hot classroom, a sweltering apartment, or a hot bus ride, is not defiance. It's a physiological event in the body that is overheating. This reframe is imperative in a clinical setting. Now, sleep and temperature are biologically inseparable from one another. Melatonin production signals the hypothalamus to lower core body temperature, which then triggers sleep onset. Rising nighttime temperatures, a direct and measurable consequence of climate change, interrupts this process. People with schizophrenia and bipolar disorder already exhibit impaired thermoregulation, which means that it makes heat dissipation from the body harder. For them, the thermoregulatory disruption is then compounded further, and their bodies can't cool down efficiently at night, so they cannot initiate or sustain sleep. And the consequences cascade. Poor sleep worsens really every psychiatric condition that we treat. It increases anxiety, agitation, and irritability. It destabilizes mood. It reduces medication adherence. It creates a reinforcing cycle of poor metabolic function, worsening sleep, which worsens psychiatric symptoms, which in turn worsens metabolic function again. So when we counsel on sleep hygiene, we must include temperature management. A fan, cooling mattress pad, cool bedroom, a shower before bed. These are psychiatric interventions, not comfort preferences. Now, I want to spend a moment on metabolic psychiatry because not only is it really fundamental to understanding the cause of some neurological disruptions, it may also be fundamental to resolving those symptoms as well. And frankly, most clinicians have not been trained in what they are and how they can help. So the brain is the most energy demanding organ in the body, and it consumes most of the glucose, the energy that the body produces. The limbic system alone uses more synaptic energy than any other brain region. And when heat disrupts the body's ability to produce and distribute energy efficiently, because the limbic system is in distress, the brain as a whole is the first to suffer. So what does this look like clinically? It looks like depression, anxiety, irritability, aggression, cognitive impairment, and even psychosis in severe cases. These are not metaphors. They are direct downstream effects of metabolic dysfunction and disruption in the limbic system. Dr. Chris Palmer, author of the book Brain Energy, is a psychiatrist and a researcher at Harvard University. He has argued that most psychiatric conditions have a metabolic component at their core. Climate change, by directly stressing the body's energy systems, is a metabolic stressor, causing metabolic distress and dysfunction. So now let's take a deeper look at exactly how climate change disrupts brain metabolism. First, elevated temperatures directly disrupt glucose metabolism and impair the brain's energy supply. Dehydration, even in the mildest form, impairs neurotransmitter synthesis, reduces cognitive processing speed, and increases emotional reactivity and irritability. And as we touched on earlier, heat and climate anxiety can disrupt sleep architecture, preventing overnight neural restoration and emotional regulation, and memory consolidation depends on it. Finally, the chronic stress related to climate-related anxiety elevates cortisol and dysregulates the system that governs mood, fear response, and executive functioning. Clinically, what this means is that climate-related metabolic and psychological stress can produce symptoms that mimic psychiatric diagnoses. For example, irritability, aggression, or anger could be related to episodic mood instability associated with bipolar disorder, or perhaps chronic irritability is associated with disruptive mood dysregulation disorder, DMDD. But couldn't it also be related to heat and temperature issues? Anxiety and hypervigilance may be a part of an anxiety disorder or PTSD, but it might also be related to environmental climate triggers. The symptom is not the diagnosis. We have to understand the context in which the symptom is being generated and appears. We can't risk continuing to put a Band-Aid on symptoms and not treat the cause. We need to move from just fitting symptoms into a set of diagnostic checkboxes to asking, what is driving these symptoms? And to be clear, the goal here is not to explain away psychiatric illnesses by blaming it all on climate change. I assure you, that is not my point. Rather, the goal is to ensure that environmental and metabolic contributors are part of the clinical picture, are being accounted for, are being addressed independently. Because in order to provide effective treatment, we need to ensure that we are matching treatment with what is actually driving the symptoms in the first place. So to do this, we have to start asking certain questions that add minimal time to the assessment, but can open up an entirely different clinical pathway. The purpose of these questions is not to find reasons to avoid giving a diagnosis. The questions are asked as a part of the differential diagnosis process so that we know whether or not climate is causing new symptoms, inflaming pre-existing symptoms, or causing someone to be vulnerable to new symptom presentation. Whether these symptoms exist in addition to or in absence of a primary psychiatric diagnosis isn't really the point. We cannot know which it is without asking, and that's the point. Consider adding these additional questions to your intake process or periodic review or crisis assessment in order to get a clear picture of symptoms and their relation to climate and environmental temperature. For some patients, when you ask these questions, it may change the diagnosis entirely. For others, it won't change the diagnosis at all, but it might instead change the treatment offered because you'll understand more about the symptom patterns and recognize that issues related to temperature could be at play. And so cooling strategies and circadian rhythm resets can become a part of a comprehensive treatment plan. Remember, the answer is never going to be either or. A child or an adult can have bipolar disorder and be more symptomatic because of heat exposure. A patient can have post-traumatic stress disorder and have worsened symptoms because of ongoing climate-related issues and stress. Asking these questions, it helps deepen our clinical understanding so we can best treat that individual who's sitting in front of us. Now, before we transition to the next learning objective, I want to close this section with a thought. A climate-informed lens, like what we've just been discussing, does not replace diagnostic rigor. It deepens it. When you ask about heat exposure, seasonal patterns, disaster history, you're not looking for a reason to avoid diagnosis. I know I've said this already, but it really bears repeating. You're not looking for a reason to avoid diagnosis, but instead you're looking for a complete and accurate picture of what is happening with your patient. Now, our third learning objective. Examine how children, women, and Indigenous communities face distinct vulnerabilities. The risks to adults with mental illness that are associated with rising heat and changing storm and seasonal patterns and shifting global weather patterns is real and substantial. But the risk to children may be even greater. Children aren't just small adults when it comes to really anything, but in this case, when it comes to climate risk. Their developing neurological systems are more sensitive to thermal stress than fully developed ones in adults. Their thermoregulatory mechanisms are less mature. They can't often recognize their own symptoms, report those symptoms accurately, self-advocate, or remove themselves from a dangerous environment the way an independent adult can. And because today's children, they live through even more severe consequences of climate change across their lifetimes than older generations have, the mental health burden that they carry is fundamentally different from what adult populations face. Studies have shown that up to 45% of heavily impacted children develop symptoms of depression following a natural disaster. More chronic stressors, such as school environments without adequately air-conditioned classrooms, gymnasiums, and school buses, are also high-risk temperature environments. And let's not overlook the reality that when children with mood disorders show heat-driven dysregulation at school, those children are almost universally misread by teachers, bus drivers, administrators as defiant, oppositional, and in need of discipline. So when we see irritability, verbal aggression, inability to complete requested tasks, eloping from the classroom, inability to follow instructions, our default framing in clinical and educational settings is almost always behavioral. This is a faulty belief for one very fundamental reason. It assumes that the person is choosing to act that way and could stop if they wanted to. The medical definition of a symptom is that it is a manifestation of disease. It is not purposeful. It is not intentional, manipulative, controlling, disrespectful, whatever word you want to attach to it that implies voluntary. It's not. It's something the patient's body is doing that is beyond their control. When those symptoms occur in the context of heat exposure in a child with, again, bipolar disorder, I go back to that because it's one of the disorders we specialize in. When those symptoms occur in a child who has had a heat exposure and has bipolar disorder and has, say, just come in from recess at school, or in an adult with schizophrenia in an unventilated apartment in a sweltering July heat dome, those symptoms are heat-driven physiological events and require compassionate intervention to reduce overheating. They do not call for discipline. Labeling symptoms as behaviors and responding with consequences makes them worse. Recognizing them as symptoms and responding with cooling interventions changes everything for the better for the individual and also for everyone around them. The clinical advocacy role of mental health providers is to change this narrative, one IEP at a time if we have to. Now, an IEP is not optional for children with thermoregulatory and psychiatric presentations. It is clinically indicated and it is a legal protection for that child. Without documentation, the accommodations, the protections that these children depend upon, they are given pretty exclusively just at the goodwill or whim of individual teachers and administrators who recognize their need and value it. But with an IEP, those accommodations are comprehensively enforceable. School nurses must be clinical care partners in this process on that IEP team. Nurses, school nurses are not an afterthought. Clinical letters, they carry weight when the clinician documents in explicit physiological terms that when a child has a thermoregulatory disorder that requires specific environmental accommodations, supports their inclusion in the IEP. The Americans with Disabilities Act extends these protections into higher ed and into the workplace. Teenagers and adults with thermoregulatory disorders who are not advocated for at this level will continue to be penalized for symptoms that are being misread as choices. As the clinician, it is our documentation, our advocacy, our voice that will help create the foundation for our clients' enforceable rights. In addition to the special considerations associated with children, research shows us that the mental health burden of climate change falls unevenly on women, and the reasons are structural, not incidental. Women carry the majority of the caregiving labor. When a disaster strikes, that burden multiplies, and it multiplies most severely for single mothers, for women in poverty, and for women whose livelihoods are tied to agricultural or coastal ecosystems. Extreme heat is associated with preterm birth, increased miscarriage risk, and gestational complications that feed directly into perinatal mental health crisis. There are documented spikes during the aftermath of natural disasters in gender-based violence, domestic violence, sexual assault, and intimate partner violence. Hormonal fluctuations across the menstrual cycle and throughout perimenopause and menopause interact with thermoregulatory function in ways that add clinically complex issues to heat stress presentations. And Indigenous and Black American women face all of this, plus the compounding burden of systemic exclusion from preparedness resources and the legacy of medical betrayal. When we ask who is most at risk, the honest answer includes women and children, particularly those at the intersection of gender, race, and poverty. Indigenous peoples worldwide, as well as in the United States, experience both the earliest and most severe consequences of climate change. Well, they honestly bear the least historical responsibility for it. The lands that were left to them after dispossession are disproportionately located in climate vulnerable regions like coastal flooding zones, extreme heat corridors, drought affected territories, and wildfire prone areas. Their food sovereignty is under direct threat. Fishing, hunting, and agricultural systems that have sustained communities for generations are being disrupted by shifting seasons, habitat loss, and contamination. In Alaska, native villages face existential displacement due to permafrost thaw and coastal erosion, leaving entire communities considering whether or not they can remain on their ancestral lands. Native Hawaiian villages face existential displacement primarily due to sea level rise, severe coastal erosion, and intensified natural disasters like the wildfires in Lahaina and storms that degrade cultural sites and force Indigenous communities to relocate them from their ancestral homes. The loss of sacred lands, the loss of culturally significant species, of traditional practices. These form a legitimate type of grief, of spiritual bereavement, for which the DSM has no adequate category. These are well documented and ongoing consequence of a changing climate for communities that can't simply relocate or adapt themselves out of harm's way. The idea that I apologize, I'm on the wrong slide. Here we go. Culturally responsive care with Indigenous clients begins before we start asking those first clinical questions. It begins with an explicit acknowledgement of historical harms, not as a disclaimer that you read from a slide, but as a genuine foundation of trust. Ask, don't assume. How is climate change affecting this specific person's community, their land, their cultural practices? Recognize that Indigenous frameworks of well-being are relational. They're land-based, such that DSM-centered assessment instruments aren't designed to capture the full scope. They're not prepared to capture the scope of the community-based grief, loss, pain, and suffering that goes along in these frameworks. Don't pathologize grief over land loss, species loss, or cultural disruption. That grief is a rational response to a real and legitimate harm. Integration of traditional healing practices, when the client chooses, gives you the opportunity to collaborate with tribal health departments and Indigenous-led organizations as clinical partners, not as referral endpoints. This kind of advocacy, such as for tribal climate sovereignty and equitable disaster response, it's not political work. It doesn't exist outside of our clinical role. It's a central part of inclusive, equitable, and ethical mental health practice. Now, there is a causal chain that runs from psychiatric diagnosis all the way to climate mortality, and stigma is the mechanism that connects them. As we discussed earlier, stigma produces discrimination in hiring, housing, and social inclusion. These forms of systemic discrimination result in lower incomes, reduced social supports, and isolation for those individuals and families living with mental illness. Lower income means living without air conditioning, not having disposable income that is needed to relocate. Isolation means there's no one to call for help when a heat warning is issued or the power goes out or a storm threatens your home. No air conditioning, weather alerts, no one to turn to. Medications or disorders that disrupt body temperature regulation and cooling all mean that a person with schizophrenia may die in their apartment during a heat wave. This might sound like an exaggeration, but people with schizophrenia are among the most vulnerable populations during heat events. And as we mentioned earlier, diet rates 200% greater than that of the general population. Studies have found relative risks in the range of 2 to 5 times higher than the general population's mortality rate during extreme heat. We've cited the 200% number that is research backed, but my point here is that additional research shows that the risk can be anywhere from 100 to 400% greater. This is not a coincidence. It is the end of a chain that begins with stigma. Clinical intervention can break this chain, reducing stigma through education, advocating for equitable housing and resources, ensuring patients know where cooling centers are, providing explicit heat warnings, and establishing crisis plans to weather and heat events just as a normal part of clinical care. Every link in that chain is a clinical opportunity. Now, we are going to head into our final learning objective, give examples of ready to implement tools for your clinical practice. Caregiver and patient symptom tracking that is shared with the provider is the single highest leverage point. It is the lowest cost clinical intervention that most providers are not using to its full potential. When you look at data that has been recorded daily over weeks, months, patterns start to emerge that are invisible in a 45-minute appointment once a month or once a week. A patient who seems to have random raging episodes suddenly shows a thermal signature. They worsen every summer. They get worse 2 days before a storm. They escalate in the evening as their body temperature rises. They can handle higher temperatures, but maybe they can't handle humidity, or when temperatures fluctuate wildly from day to day and they can't remain stable. That information changes treatment. It supports medication adjustment conversations with psychiatrists and other prescribers. It provides objective data for IEP meetings and review. It gives caregivers and patients agency and the ability to anticipate, manage, and influence their symptoms rather than simply react to them over and over again. Another simple and potentially high reward strategy is to understand the medications that your clients take. Even if you are not a prescriber, you can work with the patient to review all their current medications that they've been prescribed, including those from psychiatrists, medical specialists, and primary care providers. You can help your client identify questions to ask their prescribers. Encourage them not to bypass those pharmacy consultations when they go to pick up their medications, where they can ask for information and insight on the impact that their medications may have on their body's ability to manage heat, sweating, dehydration, electrolyte imbalances. Encourage them to ask for information and education about their medications and which ones might be contributing to a physiological heat intolerance and what they need to do differently during a heat event. You can help them to understand the importance of hydration and electrolytes, how to safely store their medications on a daily basis and during a crisis. This can involve supporting your clients as they create an emergency medication plan before the next hurricane, heat dome, or Arctic blast hits. And this is really important. Document it. Document these conversations. Put a note in the chart that says thermal risk counseling provided. Patient has emergency medication plan. It takes less than 60 seconds and it creates a clinical record that can really matter. Remember, a patient on lithium who loses power during a heat wave, who hasn't been counseled on hydration, who doesn't have a backup plan, is fundamentally in crisis. But it's a crisis that we can help prevent with clinical consultation. The clinical evidence on thermoregulatory dysfunction in mood disorders tells us a lot. It tells us that once a patient who has bipolar disorder or the thermoregulatory sleep dysregulation disorder phenotype begins overheating, the limbic system disruption that follows can be very difficult to interrupt. The interventions ideally need to happen before the overheating in order to prevent or interrupt the potential meltdown. This is why we call these cooling strategies a clinical intervention, not some sort of personal preference. Cooling mattress pads and sheets are a targeted intervention to support sleep. Neck fans prevent midday dysregulation. Cold beverages after recess stabilizes emotions. Breathable, moisture-wicking clothing is a thermoregulatory accommodation. These things need to appear in our clinical notes so you can support your clients when they are filing insurance claims, requesting reimbursement for some of these expensive items, are sending in support documentation to their school for their child's IEP or 504 plan. Those accommodations are clinically necessary, not the requests of an overactive parent. In order to help your clients and their other care providers, when you document this, you are communicating with the team on your client's behalf. Now, for families in emergency situations, go bag planning is critical. Having a cooling neck fan in the freezer, a plan where how to find the nearest cooling center. It may, in a weather event, literally save a life. Emergency preparedness planning belongs inside the clinical encounter. Not because mental health providers should become emergency planners. I want to be clear about that. But because we're often the only professionals in the patient's life who see them regularly enough and know them comprehensively enough to have the conversation with them before the disaster happens. The members of our CMHRC community who survived Hurricane Helene will tell you their roads were washed out. Their pharmacies were closed for days, There was no internet, no cash machines, no gasoline. Families who had a medication buffer, a printed medication list, and a plan navigated that. Families who didn't were in crisis after crisis after crisis. Having a written psychiatric action plan, a 7 to 14-day medication buffer, and knowledge of where the nearest cooling centers and energy centers are the products of a clinical conversation that takes maybe 15 minutes and can make a decisive difference in a patient's survival during the next climate event or natural disaster in their region. Now, metabolic psychiatry is truthfully one of the most exciting and clinically relevant emerging fields in mental health. And I want to make a case for why it belongs in a presentation about climate change. The link is this. Both climate-related stress and psychiatric illness are fundamentally disruptions to metabolic energy function. Dr. Chris Palmer, who I mentioned earlier, and his colleague, Dr. Georgia Eade, have published work demonstrating that metabolic interventions, particularly ketogenic therapy, can reduce psychiatric symptoms in some patients with schizophrenia and bipolar disorder by shifting the brain's fuel source from glucose to ketones. This reduces insulin resistance, improves mitochondrial energy metabolism, and reduces inflammatory and oxidative stress. This is published. It is peer-reviewed. It is research published in reputable journals. Well, it's not necessarily going to be a replacement for medication or for therapy, and it's not advised to attempt metabolic therapies such as ketogenic therapy without clinical supervision. It is a powerful adjunctive treatment that can give patients with mental illness a level playing field when they are faced with compounding disruptions from climate and daily life. That means that for patients whose conditions have a strong metabolic component and whose symptoms are being worsened by climate-related metabolic stress, it represents a meaningful additional tool. Now, before we move on to our Q&A, I want to leave you with 6 takeaways, one for each of the major threads in today's presentation. First, rising heat is a central threat. All of the impacts of climate change, heat presents as the most immediate and documented danger to people living with mental illness, and it is intensifying. Second, stigma kills, literally. The chain from stigma to economic marginalization to social isolation to heat mortality is documented, causal, and preventative. And preventable. Third, climate change is a mental health emergency. Its mechanisms are neurobiological, metabolic, and frankly, they're real. They're not abstractions. Fourth, medications can carry thermal risk. Every prescriber must assess, document, and counsel seasonally and proactively for heat-related medication interactions. And sixth, the future of mental health care must change. Climate change is going to reshape the demand for care. It already is. The competencies required are going to change, and we will need to make adjustments in order to ensure equity of access. That future is already here. Now, these pages here include the works that have been cited in the creation of this presentation. As you can see, there are a lot of them. And when you watch the recording of this on our YouTube channel, you can pause here and look in more detail at the works cited. For a references list, we have a references list in our continuing education portal for those of you who are interested in getting continuing education credits for participation in this presentation. There is a complete list of works cited there. And that is the end of our presentation. What I'm going to do now is I am going to stop the screen share and I am going to pull up the Q&A and review it and answer some of the questions that were not answered during the course of the presentation. So the first is about medication. This person says they have a client who takes 9 different medications. It bothers me. Can I contact her psychiatrist? So we're big advocates here for the idea that people need coordinated teams. In fact, one of the services that we provide to mental and physical healthcare professionals is that we coordinate team conversation about a client. Now, of course, under all circumstances, this requires consent. So the client has to consent bidirectionally for you to speak to the psychiatrist and the psychiatrist to speak to you. There's also no harm in getting a bidirectional release of information signed that allow you to speak with their pharmacist. Yes, you being able to have coordination of care with the pharmacist, the psychiatrist, and you as the therapist is extremely important. Now, if the client doesn't want all of their information to be shared back and forth, that is a reasonable request from a client. And so that release of information can be specific to medication and medication-related concerns. But I would encourage you to get those releases signed by the client and have conversations with those other providers with the client there, if possible, or not, but so that there's a general understanding of what are all these medications here for. Very often we see medication cocktails where medications are layered on top of one another. And sometimes that's very legitimate. For example, with bipolar disorder, which again, we specialize in, and it's very complicated, which is why I go back to it a lot. But in bipolar disorder treatment, the gold standard mood stabilizer is lithium. And so lithium is given. They may reach a therapeutic dose of lithium and discover that it's doing a very good job, but it's not as good as it really should be. And so rather than taking away the lithium, the psychiatrist may add an additional mood stabilizer like lamotrigine or oxcarbazepine in order to combat persistent depressive symptoms or manic symptoms or aggression. It's a very legitimate use of multiple medications. Other times we see, and frankly, very often we see cases where a patient is put on a medication that has a side effect. So they're given a different medication to combat the side effect. And then there's a side effect from the second medication, and they're given another medication to combat those side effects. And it just starts layering. In those circumstances, we highly recommend coordinated care conversations with the prescriber to talk about what's going on here. What are we trying to treat? And is it being treated by the medications that are being prescribed? Other times, you have folks who are being prescribed different medications by different providers for different things. Maybe they're seeing the psychiatrist for major depression, and they're seeing their general practitioner for issues related to heartburn or high blood pressure. The interactions amongst those medications genuinely matter when we're talking about psychiatric care and physical medical care. So it's really appropriate to be able to have those coordinated conversations. That is a great question. So there's another question here about resources for advocating for IEPs for clients with mental illnesses. Make sure that you as the clinician, we as clinicians, are truly up to date on what the laws are regarding access to care. I've partnered with many wonderful school districts and wonderful case managers, wonderful special education teachers and departments. So please don't take what I'm about to say as though I am disparaging schools in any way. However, that said, very often it is a burdensome expense for a school district to have too many kids who have IEPs. And schools can be resistant to allowing an IEP for a student who they think can be managed with just a 504 plan. As clinicians, it's our job to advocate alongside our clients for the best possible care and accommodation based on what their needs are. And so oftentimes that's knowing what disorders are specifically covered under the Americans with Disabilities Act, as well as in the IDEA, which is Independent. Now, why am I blanking on it in this moment? I say this one over and over again. Individuals with Disabilities and Education Act. Knew it would come to me if I gave it a second. Knowing what is explicitly called out as a disorder that requires accommodation in the form of an IEP. So that is the first thing. The second thing that I would say in terms of advocating for our clients who need IEPs is to document, to be willing to put into a letter that is backed up by your clinical documentation that this person, this child, needs these accommodations and why. Your knowledge on that subject is going to be one of the most important tools the family has in pushing their school to give their child that IEP. Also, it helps to have additional education and continuing education around how to write accommodations that are social and emotional. I give teachers a tremendous amount of credit for being able to write objectives, goals, and accommodations for IEPs that are appropriate for learning disabilities, other specialized learning needs. But teachers are not trained mental health professionals. They're trained teachers. And so when we're talking about writing social and emotional goals and objectives and accommodations for an IEP, as the mental health clinician, you have a role to play there. The family can request that you are at that IEP meeting with them. Either you walk in the door or you're in that virtual room with them, advocating for the fact that this child needs this accommodation, that they are not to be judged based on their symptom presentation. They are to be judged on their ability to manage their symptom presentation, which is a process that develops over time as a result of age and developmentally related challenges, as well as symptomatic challenges. So I would say the most important resource for a family that is looking to get an IEP written that includes what is necessary to treat their child's mental health condition, that most important tool is you, their provider. Okay, next question. How do substance abuse and other impacts, how would substance use further impact or compound the effects of heat and climate dysregulation? It's a really great question, and SAMHSA has information on this, or at least they did. I don't know if it is still up on their website, but also impact the body's ability to effectively thermoregulate. Just as prescribed medications can interrupt the body's thermoregulatory processes, so can illegal drugs that can be taken without, obviously without any medical supervision. So the important thing to do is look them up to determine whether or not those medications cause thermoregulatory interruption. Whether or not those recreational or addictive drugs are also impacting temperature regulation. It also, you'll want to look at whether or not they are disrupting melatonin production, because as we discussed, melatonin production reduces core body temperature. Reductions in core body temperature are what trigger sleep onset at night, which is, this inextricable link between temperature dysregulation and sleep onset, duration, quality, all of the above. And so you want to be looking into how are these other substances impacting sleep? How are they impacting melatonin production? How are they impacting the body's thermoregulatory system? How are they impacting the amygdala? How are they impacting the hippocampus? We want to make sure the system is not being triggered, which can absolutely happen when people are taking medications or illicit drugs that act as stimulants. They also impact metabolic functioning by suppressing appetite, reducing the amount of energy source that the body and brain have at their disposal. We also have a question here about the difference between the behaviors and symptoms, which is something that we talk about all the time. It is absolutely an essential piece of understanding how to work with and support someone who has a mental health condition or a mental illness. And I say that because it's not just children who suffer consequences as a result of the presentation of their symptoms, it's adults too. I'm reminded of an event that occurred that a member of our community, the parent of a child who lives with a mental illness, was in a Facebook group for their geographic community. It was like a town, county-wide Facebook group where people would post interesting things about what was going on in their area. And someone posted with aggravated concern that there was a halfway house for people who were being discharged from psychiatric inpatient units in the neighborhood, and that it was unmarked. This person was very unhappy that this halfway house, this transition location, was unidentified, and how people in that house could harm the children in the neighborhood. And they really felt as though it was a necessity that the community demand that either this house be moved out of their community or that it be labeled publicly with a sign identifying what it was. Now, as one could imagine, this really bothered the member of our community who saw this, who responded by saying, people who have psychiatric disorders are entitled to live in their community, are entitled to the least restrictive environment necessary to maintain their stability, mental and physical health. There is nothing wrong, and demanding that they be publicly identified in this way is a violation of their privacy. It's a moral and ethical violation against them, and is rooted in stigma and discrimination. Subsequently, that post entirely, not just the rebuttal, was taken down. No one knows if it was taken down by the person who posted it or by an administrator on the town account, but nonetheless, it disappeared. This misunderstanding about the difference between symptoms and behaviors affects people of all ages. And what we really have to understand is that when we're talking about symptoms of a diagnosable illness, as I said before, symptom itself, the word is defined as a manifestation of an illness. We don't blame someone for intentionally choosing to have a fever when they have the flu. We don't blame someone for intentionally choosing to cough too much when they have bronchitis. We recognize these things as being just basic facts of having that illness. The difference is that a fever or a cough is something that can be externally observed and measured in a way that is objective. And we don't give the same benefit of the doubt to people whose symptom presentation occurs because they are experiencing a psychiatric disorder. So thank you so much for being here with us today. If anybody has any additional questions, please feel free to email us at admin, ADMIN, at cmhrc.org. Or if you have specific questions about our continuing education program, you can also email learning@cmhrc.org, and someone will respond to you as quickly as we possibly can. Thank you so much for being here with us, and we will be back in August for our next round of courses and webinars in August, September, October, and November. We look forward to seeing you there. Don't hesitate to reach out. We are, as always, here to help. Have a great night, everyone.